Dr. Vigilance is our Vice President of Social Impact and Population Health, and his interest in social determinants of health really spans not only the veteran population, but really all people, but in focusing on those underserved populations. It's an element beyond electronic health records, beyond the biological, that has a impact on health that is just starting to be realized.
So before I get into introducing our illustrious panel, I wanted to sort of do a quick recap from this morning, because I think there were some really sage comments made, and we definitely want to dive into this conversation with these folks who have joined us today. And so Colonel Sutherland this morning highlighted a couple of different things. In that Sea of Goodwill document, he talked specifically about the fact that this trifecta of education and training, care and wellness itself, as well as employment, were essential to family wellness, if you will. And so that was a great introduction to this notion of social determinants of health, which obviously go beyond those three things, but are very important. He said, when you've met one veteran, you've met one veteran. And so it's important to recognize that every one of these veterans has different needs. And I think that that's also something that should be taken into consideration as we talk about vulnerable populations just in general, and that cookie cutter solutions, as he referred to, do not work. Care needs to be more precise, to enhance outreach, program design, human interaction, and embrace the unique identity of each individual. And the third thing he said that I thought was particularly poignant was we have to solve the epidemic of disconnection, and that another huge piece of this social determinants conversation. Dr. Allard, CEO and founder of the Community Health Design Institute, talked about housing and the mental health and substance abuse impacts associated with that, but how that again impacts a number of other factors related to care adherence, nutrition, etc. Nathan Ludke, a public health professional, community health professional who's been in the local and state government levels of public health, talked about healthcare being complex at a baseline, and the community-based solutions are what make the difference. And then Dr. Whitehurst came back to that conversation about navigation for veterans being something that was very easy for them of their healthcare while in the service, but once they get out of the service, it becomes a bit more of a challenge. And so we have this opportunity at the moment, especially with, and we'll talk a little bit about this, the American Recovery Plan, to do a few different things. One of them, catalyze health equity initiatives. Another one, modernize public health infrastructure via data modernization, which can mean a number of different things. Another one, which will be huge, is to build public trust, particularly in our public health systems. And another piece, which I wanted to use as a segue into this panel, is innovation starting with better communication. And I think that it's really, I feel very fortunate to be associated with all three of these individuals. I'm going to make some brief introductions of each of them so that you can get to know them, and then I'll let them each give a couple-minute sort of opening set of remarks related to social determinants and leveraging technology to address them. The first person I'd like to introduce is Matthew Goudreau. Matt Goudreau is the Vice President of Operations at Activate Care, which is a Boston-based social determinants of health collaboration and referral management software. Matthew has a public health degree in emergency management and held a National Registry Paramedic certification for almost 25 years. He's internationally recognized in the field of mobile integrated health and community paramedicine, something you heard Dr. Allard refer to earlier on, which has afforded him the opportunity to be published multiple times and is represented internationally on the subject. He has a leading role in designing, implementing, and operating cutting-edge care delivery models that think outside the established methodology. So thank you for joining us, Matthew. Joining us is Joshua Prasad. He is focused on health equity as the Director for Health Equity Innovation. And he is focused on health equity through public health innovation and community. He is with HHS, Health and Human Services, and prior to joining Health and Human Services in 2020, he worked at Deloitte Government and Public Services Consulting, where he led projects in the social determinants, health equity, and COVID-19 related disparities until early 2019. He was Center Director of a rural health center and has focused on national initiatives like Public Health 3.0, the first federal framework on social determinants that aims to re-envision public health at the center of communities. He completed an Innovation Fellowship at Harvard Center for Primary Care in 2016, has a Master's in Public Health from Drexel University up here in Philadelphia, and his Bachelor's from Rutgers. He's currently in the DRPH program at NYU in their inaugural class of 2021. So thank you for joining us, Josh. And last but not least, Dr. Barry Lewis is a population health executive from Absolute Total Care, which is a Centene health plan. As the Chief Medical Officer, he has oversight for the quality of care administered for a Medicare, Medicaid, and health exchange population. He applies a collaborative approach to uniting healthcare stakeholders to achieve exceptional clinical outcomes. He is driven by a national charge to expand access to care, improve care experience, and enhance accountable utilization. He strives on being a community steward for well-being objectives. He has his undergraduate degree from Vanderbilt University with a BA in mathematics, and received his medical degree from the University of Tennessee in Memphis. His residency trained at Johns Hopkins Hospital, and later received his Master's of Business Administration at the University of Tennessee. So thank you, Dr. Lewis, for joining us. If I could ask each of you to take a couple minutes before we get into our sort of more round robin conversational style of this afternoon, if you would, we talked a lot about this being a social determinants conversation. Social determinants were outlined earlier on. I mentioned a few things just now about some of the comments made about what's peculiar to or particular to some of the veteran-related issues, which I think also apply to vulnerable populations in general. Your take on sort of your comments on opening remarks related to social determinants, achieving health equity and what that means or looks like for vulnerable populations, and how we might leverage technology and or data to better be able to get to that. So your opening remarks with respect to that, a couple of minutes each would be great, and then we can get into our conversation. If I could start with you, Dr. Lewis, would that be good?
Absolutely. Hopefully you can hear me well now. Are you able to? All right, good. Appreciate the opportunity to be able to speak to everyone here. And I will start off like this. I remember being in medical school, first, second year. We got this huge textbook about 5 inches. It seems like it's 5, 6 inches deep, and Robbins pathology. And you're supposed to know everything in Robbins for the next test that was coming up in 1 month. You only had about a couple weeks to prepare. In that textbook, it went over all these medical conditions. In those conditions, it would say your risk for them. It would give you your mortality, likelihood of surviving, and it was there, up and open, shut, closed, that's it. In that evaluation of a particular condition, it might tell you that based on your racial background, ethnic background, you have a greater likelihood of this. And that's it. That's all you had. You had no way to get around it. You had a diagnosis, you had a lifespan that you expected to have, and that was about it. And it was greatly a disadvantage for people of color from looking at some of that information. Well, I'll fast forward many years into my practice and getting to the health plan side. So as the Chief Medical Officer of the health plan, lots of information comes in. You've got all the information about encounters, whether it's inpatient, outpatient, and this is going into different databases. And then all of a sudden we had our care managers, and we talked about the outreach in the program today, but the care managers were expected to do certain things. And then when I looked at some of the programs, they were pretty simple. It was identify certain conditions, understand what's going on in the person's home or in their own environment, what's keeping them from doing what they need to do to take care of themselves, what's preventing them from taking their medications. And if you could do that, there is a greater chance that you can improve their outcome. So what I took from those two experiences that I'm sharing with you is that it isn't an open and shut case. It's really significantly about social determinants of health. They come up with some of the numbers, and social determinants of health represents about 5 different categories, whether it's where you live, your environment, your education, what access you have to hospitals and care. And then they say 20% of it is what that doctor tells you what to do. That leaves about 80% of something else that has to be managed. And that's what I learned to be so effective in the environment that I've been in the managed care setting, working on the health plan side. Doesn't take a rocket scientist, someone with a super advanced degree. It takes someone who's compassionate, knowledgeable, who is really committed to influencing the well-being of another individual. And that is all mitigated by or advanced by the information that's shared in our data platforms that are coming in. We have, as I mentioned, we have information coming from so many different directions. And so putting those all together, social determinants of health means a lot to me personally, for the well-being of other individuals. We actually have access to various populations. We have a commercial plan, Medicare, Medicaid exchange, so some of the most vulnerable populations. And for me, that transfers over to about any population across the world. So that's a little bit of my intro. Thank you very much.
And thank you, Dr. Lewis, for that great intro to try and follow. And thank you to everyone here for having all of us. It's really inspiring to hear some of the work that others are doing and the real impact we're trying to I think, talk about and hopefully really deliver too, from all our different perspectives. I think I also have a pretty personal connection to social determinants. I spent most of my career working in this space to try and advance it from where we have been to where we're hopefully going. And that's why I actually joined the department earlier this year to try and take an opportunity and accelerate it. And I think that's what we do here in the innovation team at HHS. So I'm the director of health equity innovation here, and a big focus of that is on the social determinants. I'll say that having worked sort of at the federal level, federal national level, I've worked in the health tech space and worked on the ground in a variety of different capacities. Something keeps popping up every time, and it's the need for more connectivity between sectors and really elevating the ability of local communities as the place where people live, work, play, and pray, to be able to be a place that people can live in and be resilient and not just survive but thrive. So I think that with that in mind, that's largely the focus that I bring to the social determinants conversation. Like Dr. Lewis mentioned before, we know that some 80% of our health is determined outside of our clinical interactions, and so it is our impetus to think outside of the box, or outside of the clinic, as it were, to really designing what communities look like and where people do everything else except their clinical interactions. Some of that I think has been addressed or starting to be addressed through the referral systems that are sweeping the nation, as it were, and the social determinants conversation. But we also need those to work hand in hand with rebuilding community. The pandemic has really opened up that opportunity for us to actually not just address COVID-19, but address the factors that are causing disproportionate cases of COVID-19. A lot of those are happening in BIPOC populations and other vulnerable populations. And so as we address the community needs that they have there, hopefully, I think part of my vision anyway here at the department is to make sure that we are thinking not just for the pandemic right now, but preventing future pandemics. And really a lot of that is about how we can actually build communities to be resilient towards all other sort of health maladies. I'll just finally note that I'm really excited to dive into these conversations further, and the note about veterans as just one population is really important. When we think about social determinants, when I think about social determinants, it's oftentimes why is this not more focused on Black populations or Indigenous populations or veterans? And I think that's one of the unique things that we can think about from an equity perspective here. Health equity really can be for all, and if we're redesigning community-based systems, that can impact and affect everyone who lives in those communities, whether those are physical geographical zip codes that people live in or other types of communities that we have. And so veterans, I think, very much fit, veterans and people who serve in the military very much fit into that conversation, and I'm eager to make sure that they're included in that conversation as well too. So thank you.
Great. I'm really excited to have the opportunity to present here. You know, Pierre mentioned I have 30-year experience as paramedic, and one of the interesting things about coming into the social determinant space from a paramedic background is that we went into people's homes, and our care started where they live in their world, and we really exposes the EMS professionals and fire and police, all of us, to a different level of understanding, or worse, not understanding how we got to this place in this individual's lives, and feeling very helpless and being able to help them move to a different and better place. So we were reactionary. We were dealing with something in the moment and helping them in that particular instance, but could see the other things that were going on around them and didn't really have good avenues to help them. And about 10 years ago, I was lucky enough to work with a really amazing group up here in Boston, Commonwealth Care Alliance, to build a community paramedic program where we took our paramedics and we used them as a kind of an alternative care delivery system where we know these patients, we know the world that they're in, they trust us, we walk through the doors paramedics and they can relate to us immediately. And we were helping them in very different, unique ways. It was a really empowering experience, and it really opened my eyes to the things that were capable of being done and how we can take traditional healthcare delivery systems and use them in totally different ways to really have a more impactful, overall care delivery model. And so it was great. I loved it, and I did it for a long time. And then one day I woke up and said, I don't want to be the community paramedic guy. As I'm traveling around the world presenting at conferences, and I really wanted to do more. And so I was really lucky enough to come to Activate Care and be able to participate in a software system that was working at the heart of trying to tie together care in the social determinant space. A couple of things that really stood out to me when I looked at this opportunity was that their goal is to bring all the players together. And I heard Colonel Sunderland say earlier that it's a whole community approach, and that's really what we're all about. We're trying to pull together healthcare and behavioral health and the CBOs that are working in the local space and community health workers and various entities to bring them together in a singular space so that we're treating the individual as an entire individual. One thing that really stood out to me in listening to various stories and conversations today is that we sometimes forget that because we've fractionalized our care delivery systems and we have those data silos as well as care delivery silos, that people of traumatic backgrounds unfortunately have to commonly relive their traumatic experience by retelling their stories over and over and over again in various settings. And every time they interact with the system, it's a painful experience for them because they're retelling something that they've told far too many times already in our system. And it's part of the underlying reality of mistrust in our system and why they don't want to seek out care and why they're hesitant to go back into it because we're reopening those wounds and reopening that trauma. And out of that comes part of where we stem from, which is trying to get everything in a singular place, that we're looking at the individual as an entirety. We use the term whole person care because we've done a ton of work in the state of California with the programs that are out there and understanding how they're wrapping these patients with various levels of care into a singular platform and getting all the information, full visibility in a singular space where more people can interact and play a role and see everything that's going on, and really reminding ourselves that these people in vulnerable populations, there's a lot more to them than just the individual piece that we're treating as an individual provider. We're really looking at them in the entirety. And so that's really where Activate Care comes from. We believe that health equity needs to stem from that level of getting everybody on the same page and have everyone participating in a singular kind of mindset moving forward. One of the other things that I've learned recently is I've really been thinking a lot about, we have this amazing opportunity right now with social determinants of health that we have not had ever in the time that I've been looking at this in the past decade. And that is that there's funding. And that's something we haven't seen. And that funding means a lot because now we can start thinking about doing things differently than we've done them in the past. And I think that that's going to be really, it's an amazing opportunity, and it's a really great time to be in the space and really exciting time to try to work with various groups to talk about social determinants and how we address it. Foundationally, I think that one of the biggest things that we have to overcome is the fact that social determinants is part of a healthcare system, but it doesn't necessarily need to be embedded within the healthcare system. And I think there's a potential to move it to work alongside of a healthcare system in a way that allows these CBOs and allows these boots on the ground people to be doing this work and sharing information and sharing visibility into what's going on, but doing it not necessarily within the healthcare system. And I think that that's part of what we're trying to to start to dig into, and using a collaboration tool where we can bring in the healthcare component, we can bring in the payer component if necessary, we can bring in the CBOs that are doing the work and put them into a singular space and give them a place where they can do this work. And so it's a really great time to be in this space. There's a lot of work to be done. Foundationally, we have to figure out not just how to treat this problem, but can we treat this problem? And what I mean by that is there is nowhere near enough resources to meet the need in the social determinant space. And we really need to dig deeper as a society into where are our existing resources, what are the capacity of those resources, and where are the gaps? And I think the gaps are far more substantial than we're aware of right now. And hopefully part of this initial phase of coming out of funding this is that we can get to the heart of the matter of understanding. You know, we talk about food deserts, we talk about healthcare deserts, but it goes way beyond that. And understanding, okay, it's great that we have 5 food pantries in this area, but each one can only handle 100 people, and there are 5,000 people with needs. And we have to get to that level of detail from a population health perspective to really be able to address this issue, because we can build all the software systems we want, we can build all the pathways we want, but if we don't have the resources and the communities to meet the need, we're never going to meet the need.
The first question that I want to throw out to you is sort of, you know, social determinants of health is having a moment. And I think that it's always kind of interesting to me, as Dr. Lewis was thinking about or talking about medical school, which I won't say how many years ago that was for him. And it was a decent amount of time ago for me, but so social determinants of health are not new, I guess is the thing. And so there's nothing really new about this notion that health is much more than health care. But it's having a moment, and I think that it's maybe fair to say, and this might be a bit, it's inflammatory, but you know, we're looking at the privatization of social services is probably something that is imminent, and a number of things that go along with that mean that we've got to be addressing social determinants far more aggressively than we have been if we're going to be impacting cost and if we're going to be impacting outcomes. So as you look at this space with respect to the number of people who need to be engaged, I think of Tom Cruise in that movie Minority Report and all these dots that have to be connected in order for them to solve the crime. There are lots of sources for places that need to be engaged. Where do you see from a public-private partnership opportunity, and this I think applies to all of you, because even if whatever space you're in, the opportunities to be public-private partners is sort of there. What sort of excites you most about what that looks like going forward? So if you're on the private side, how would you like to be partnering potentially with municipalities? If you're on the government side, what do you see, Josh, as the potential opportunities for partnering with the private folks? So I'm going to start off with you, Josh, from the government side of things, if you don't mind, and then we'll go from there. But what sort of excites you about the promise held by public-private partnerships and other collaborations to address SDOH?
Yeah, no, I think it's a key point you're hitting on. And so it's definitely, I think the word you use is moment. We're having a moment in social determinants. Matt, you mentioned it before too. And I'll actually just start by saying there was, like 5 years ago, 6 years ago, I tried to found a social determinants-based startup, and it was really hard to get funding for it, a little bit. And in the time since then, it seems like not only is there venture capital funding for more health tech stuff, but their funding is really flowing in such a unique new way to try and address these really critical different problems. And you mentioned, Pierre, you mentioned before, I was part of a framework development here at HHS called Public Health 3.0. That was, I think, 2015, 2016. That was one of many indicators out there that we're trying to change the conversation around social determinants. So I think in that time, we've seen a massive market shift, if we will, moving toward these upstream factors, and it's brought in key thought leaders and resources and innovations to the space that I think we should be really happy to see, which is great. The promise, I think, of public-private partnerships is a pretty critical one, because especially from my perspective in coming in government, but also working in communities, like I said before, there are largely many problems that can't be solved just solely by the free market, the private companies that go out there. Y'all in the private sector have bottom lines to meet, and it's really hard to justify solving homelessness or solving a food desert just because of the goodwill of your corporate hearts. And so I think there are needs there. And similarly, we in the federal government certainly, and in other parts of other types of government too, do not have the speed and agility and ability to bring in the best experts or problem solvers to solve those problems in the timely way that it needs to be. And so I think that's really where the opportunity for public-private partnerships can really be a good one. I think you mentioned something about how does technology factor into that, and I want to just address also as someone who's played in the health tech space too, that especially when it comes to social determinants, and I personally see a need for permanent, sustainable SDOH change, and that doesn't necessarily mean technology is baked in there, or it starts with a technological solution, but I think it can benefit from technology when we're talking about solving homelessness or food insecurity or these other major social determinant areas. I think that starts with, how do we get a roof over someone's head? How do we get someone eating a meal today and long term? And if there's a tech way to do that, that's great. And so I personally just looked at a lot of the conversation around social determinants, health equity, et cetera. And maybe this comes with too much cynicism, but selling the app, selling the UX, selling the IPO numbers for health tech, that's great. Those aren't the things we should be tracking. We should be tracking how we're actually scaling improvement and really delivering impact. And that's part of the conversation I think we need to get to as well. And so I'm really excited at the opportunity, knowing that I personally work in an innovation shop in a very slow and old organization. It's hard for us to, build things, but we need to. That's why I think public-private partners really work. And so that'll be one thing I'll note is that I'm on the HHS innovation team, which is actually a rebrand of our old Chief Technology Officer's office, which you all might be familiar with from some of the work we might have done in that capacity. But the rebrand, I think, is actually pretty critical because innovation, specifically public health innovation, in the moment we're in now, requires not just technology solutions. It really requires rethinking systems, some of which are grounded in technology and some of which are, how do we redesign something more holistically, and maybe there's tech involved and maybe there's something else. And so all of that is to say, I think we can't do it alone in government. We're looking to our key partners in the private sector to help work with us, and we have the reach, we have the impact, we have the ability to scale. We just need the tools and the brain power to help do it.
So given that, and thank you for that, Josh. I have the suspicion, and Matt, you could tell me if I'm wrong about this, that from a nimbleness perspective, you have some greater nimbleness than Josh might have with respect to speed of building and getting things out there. I could be wrong in that, though. I think there's this perception that when you do things as a startup and you do things in the private sector, that everything moves so much quicker and smoother, but we know that that's not necessarily true. From your perspective and thinking about this public-private partnership opportunities, Activate Care, how have you looked to leverage those government relationships to be able to make what you offer of value to the clients that you're serving?
Yeah, it's great. It's a great question, and it's true. I mean, I agree with everything Josh is saying. That this really there's a place for technology. There's a place for policy change. There's a great place for a lot of these aspects that all need to fit together. And some of them are going to come from the private sector, and some of them have to come from the public sector. And but I think that one of the foundational key elements for all of this, for me, is outcomes data. We don't have good outcomes data, and I work in the field, and I work in the technology that's trying to drive outcomes data. And what we hear consistently from state agencies, from county agencies across the board, is that we're building programs, we're providing services, but we can't actually show how much of an impact it's having on the bottom line. And part of that is because of this fragmented data structure that we have, that we've built things in various places, and we've locked off elements of that data from each other. And so we can't go from an end-to-end data set to be able to say that, okay, this policy change resulted in the ability of, a county organization using technology to do this actual workflow, and then the byproduct of that was what we met a need, and that need saved money back at the beginning. And we can't tie that all together because it's too fragmented. And so really what we're seeing in the private sector is, yes, we've got technology that allows us to bring that into a single platform. We refer to our system as a community care record. Like, we're approaching this from an EMR type approach, but on a community care record basis, so that the work that's being done is in the community. And the goal of it really is to be able to get the full outcome end-to-end data set in a singular space, so that we can bring that back to our partnerships that we have with the public sector, and actually help them to draw the correlation between the actions that they're taking and their policy changes and the outcomes that is happening on the street. A lot of it right now is theory-based. Like, I love the referral management platforms. We work with the big ones all the time, and we all know what they are. They're great, and they serve a purpose. But the reality is that the overwhelming majority of the work that's being done is in some community health worker's little black book, and she's sitting with someone in the emergency room or in a health center, and they have need A, and she's calling John at the local food bank and connecting this person to resources with people that she knows extremely well. And it isn't even going into that referral management system. The referral management system is being used for the stuff that she doesn't have an answer for in her little black book. But what's equally challenging in that is that little black book isn't creating data. And so we still live in a data void on many, many levels, and right now we're trying to work with the public sector and private sectors, but a lot of our work is with county-based organizations, or we're state-based organizations, where we're trying to say, okay, let's connect the dots between the referral, the need was identified, the referral was made, actions were taken, the referral was met, and the outcome is this, and putting it all into a singular data set so that we can then go back and say, great, this is the outcome that we saw. This is how it can help you drive policy change. And equally as important, as I was saying before, is where are the needs not able to be met because we don't have resources available. That's a critical component to this that is still grossly lacking, especially in rural areas where we may have a food bank in every 3 to 4 towns, and then we end up with the inability to get people to the food bank because of transportation issues, and they all layer on each other and become a complex reality of trying to get these needs met. So that is a big piece of this. The last piece I just want to touch on real quickly is, I think the public-private reality has been going on for a long time, right? We have most of the CBOs that are out there today they're being grant funded off of philanthropic resources or something else, and there isn't really public dollars that are driving them to do this work. They don't get paid for out of the public dollar, and yet the work that they do saves the public dollar. And so it's really fascinating to me that there's this disconnect between funding those very resources that are critical to meet the need, and getting them to be able to increase their capacity and actually address the volume of need that does exist, when the savings is actually having an impact on typically a Medicaid type system, and we're seeing that across the United States. So that's where I'm hoping that we're going to get to with some of the new funding that's out there now to the public sector, to be able to say, let's fund some of these programs in ways where they can actually meet the need, we can actually get that result. But again, in order to do that, we have to have outcomes data to be able to go back to the policymakers and say, this is what happens when you address these needs.
Right. No, that's well stated, and you're sort of making me, as a pivot to Dr. Lois, and wanting to put the same question to him, but also want to sort of harken back to, his clinical training and anesthesiology and critical care, and there being an impact based on, if we do this, then this will happen, and there being this causal relationship between an intervention that we put in place for a patient and what actually happens with their blood pressure, their respiratory rate, or whatever it is. As you talked a little bit earlier on about being more outcomes oriented and wanting to push in that direction, do you find it, I don't know, I know it's plausible, I know you agree with it, but how easy is it for you all to be able to engage in what we talk about as public-private partnerships from your perspective? And are they things that we need to look at and think about how to do differently to enable entities like yours to be able to do more of what they need to do or want to be able to do for patients to drive those outcomes that you were talking about?
Yeah, from the health plan perspective, in order to survive, we have to have connections with the stakeholders. So it's a public-private engagement all the way around. Otherwise, we're just not going to make it. So that's pretty easy for us. Is it easy to do? Yeah, it's pretty easy to do, but the limitation is time and focus and being on the same page with the other entities you're working with. So from a private standpoint, I'm saying private to private, working with some of the smaller organizations or some of the what we call vendors out there is this great interest in driving improvements in certain areas, whether it's in opioid use or identifying behavioral health needs in different populations there. We don't have enough of the local internal team to keep working on that. Staff, we can only staff so many folks. So you have to bring in these partnerships there to try to improve in those areas. From a public-private standpoint, our products are government products. So we only survive because that's where our contract comes from. So we speak to them, and we have to speak to what their needs are. And fortunately, the needs are based on some other agency recommendations about what's considered quality, what's considered a quality outcome. We have this data set called the HEDIS data set, in which insurance plans and managed care plans are measured upon. It doesn't necessarily correlate with the best outcome overall with everything, but it creates kind of a pace, a direction that you should be going towards. If you've got a certain behavioral health condition, if you've been put on medicine for a kid for attention deficit, do you have a follow-up in 30 days? If you've had a hospital admission, do you follow up with a doctor afterwards? Are you taking a certain medication to improve your diabetes, a statin treatment? So we have these guidelines that are out there. It's the alignment with the public side of the world, and it is the partnership with our various vendors and private entities that allows us to drive towards improvements in care. So going back to kind of your question up front, social determinants is having a moment. Yes. The question is why? Well, we could all go around around the board here on what some of those things are. I like to add a couple things. One is dollars. We're up to 15% of our GDP being spent on healthcare. We just can't survive on that line item being spent on healthcare. So in addition to that, if you look at all the money that we spend in the U.S., if we've had some, maybe not the best outcomes data, Matthew, but we've had some outcome data in the sense that we have more advanced disease in the United States versus other well-to-do countries, right? We have greater suicide rates. We've got lower lifespans relative to other countries that are high financial earning countries. Why is that? And so that's the motivation to say that we can't sustain ourselves in the direction that we're going. We've got to do something about it. And so that is creating this urge and this hunger to create solutions. And thank goodness that there is awareness about equity and social determinants of health. Here comes the pandemic. COVID comes in. We're sitting around and we're saying, well, you know what? That's going on in China. That's not going to affect us. They've had some other things that come through. They've had some other SARS infections that come through, and we're going to be okay. Guess what? It comes in within a couple of months, and it takes over the U.S. We've got supply chains that's been affected across the world. We've got all kinds of issues. So we now have this realization that we are an integrated world. Funds only go so far, and we need to improve, and we can't isolate and say, well, it's only the frontline workers that are getting sick, so I'm going to be okay. We realize that we have to do something. So with that has created the motivation for these relationships and interactions between public and private side. And I think that it's just the right place, the right time to move towards advancing health for a greater population instead of those who just have the means. And then we've got the technologies out there. This is, a discussion about the platforms. A lot of things I've been looking at, it's like predictive analytics and the predictive modeling. And, these are all big words and fancy words. It's about pulling data together, as the team has talked about, put them on platforms, and then we figure out how to use them. But we've got these tools out there. We put them in the right hand, the right people. We could advance the health of our population. Maybe it's a step at a time at a certain population at a time, certain groups. And when I say groups, I mean maybe condition groups, not necessarily background or origin groups, but we do a little bit at a time, and we take that and we transfer that over to other populations. So it's going to take a collaborative approach to get to where we need to go so that we don't run out of money.
No, I think that's well stated, and I think that it's as much as we've had these conversations before about the system costing a significant amount of our GDP and people not necessarily benefiting to the level that we feel that they should, given all of the resources that we have here. We do an amazing job in this country of providing excellent care at the beginning and the end of life, and in between, folks kind of get, I don't want to say lost, but they do to some extent get lost. And for different populations, that means different things. So we have these disparities that we've been talking about for a very long period of time, some of which have other completely non-medical backgrounds to them, but that sort of have social backgrounds to them, historical backgrounds to them that impact how and why care is provided in certain places to certain folks and not to other folks, or differently to one group than the other. Your comment just now, though, about the analytics is sort of what segues me to the next question, because we talk about predictive analytics, and it's something that, as our CEO Heather Flannery talked about before, we talked a bit about machine learning, we talked about leaving data in place to be able to do that, as opposed to having to share data, that being a concern with respect to, are you going to steal information from me, etc. Is there a way for us to have machines learn without data having to move? And there are federated learning models for that to be able to happen. But machine learning is a hungry beast, right? Machines need to get fed a bunch of different things in order to be able to predict something. I like to use the analogy of food because I love food. So if you were to say, if you were to only feed a machine burgers, and then all of a sudden throw some roti and curry at it, or throw some chicken tikka masala at it, it would sort of say, what is this? It'd have no context for what that other, quite delicious, by the way, meal option is, because all it knows is burgers. And so we have to do a different job with respect to how diversely sourced data is to get into those machines for the algorithms to do their learning and do what they have to do from there. So that sort of gets me to this next question, which is, data comes from a number of sources necessary to paint the most accurate picture for us to be precise about the population health that we actually put in place. And so as we think about that little black book that Matt was referring to, I love that, the community health workers little black book. As we think of that little black book and it having this treasure trove of data in it, how accessible is that little black book to the community-based organizations that those patients are served by, and also to the health systems that those patients are served by, that community health worker stands in the middle of, right? That community health worker is between those different systems. And how accessible is that social determinants data, and how are we going to be able to better draw on that information to inform care and inform the predictive analytics that Dr. Lewis was mentioning? I don't know, we can start getting into popcorn style here. I don't know who wants to jump on that first, but the community health worker little black book, how do we free the data from that little black book and get it to the right places so that predictive analytics can be more predictive for more people and more useful?
This is a really interesting conversation for me because we're coming at it from a little bit more simplistic approach, but I can see where the reality of what we're trying to create feeds into a bigger model, as you are all looking at right now. We recognize that we, as a software, we need to be able to bring a lot of people together so that we can do this in a singular space, so that we can create a database that's a single database that tells us the whole story from that end-to-end perspective, right? we're not in a place right now where we're saying, okay, what do we do with that data after we get there, other than to try to help the partnerships that we have with the public partnerships to drive policy change. But I think that my experience in bringing in data into our platform through various integrations, we bring in ADT data, we bring in HIE data, we bring in HMIS data for homeless systems. We a lot of different components of data into the system in order to help to drive the type of care that our caseworkers are actually working on. And all of that data is you're able to get it. It's a process by which to set up integrations with individual systems and exchange, the touch points and do the connectivity and pull the data in a regular cadence, and then make that data actionable, which is really the biggest piece of it from what we're trying to do is take this information data set, make it actionable within our system. And then from there, what's the next step? I think it would be amazing to take a system like, systems like ours and say, all right, feed it into a system where we can run machine learning. At a bare minimum, that data needs to get fed back into the healthcare system, because the healthcare system is going to change things that are happening in care delivery on their end based upon what we're doing. But we're not at that point of putting it into a machine learning stage yet. But I think it's a great concept.
I would say it's a tricky question, Dr. Vigilance, because the reality is we have these different organizations out there, and they have some proprietary models and systems that are there. They're trying to build them, develop them, and not all models are the same. We have a model that we use. It's called Impact Pro, that we use for identifying risk scores for our members based on the accumulation of information, whether it is your pharmacy utilization, your inpatient visit, the time of your inpatient visit, an ICD-10 code or diagnosis code that's provided. It's accumulation of all the data that they can collect, and it's still plenty of information that's not there, right? So you've got another product. You got that natural language processing, which, because you have information that's on a piece of paper that doesn't come in. So the point is, there's tons of information coming in. We're able to create that to create a risk profile. In addition, we actually work with an outside group that brings in social determinants based on the address or zip code that's put into the system. Create a risk score. We give this information to a care manager and say, hey, this is a high risk patient that we're going to need to do an outreach. We think that the condition is this, so please take the next step. The reality is that that care manager still has to do a little bit of processing, because you still have to improve the models. So you're improving your models, you've got this information, you're trying to have an impact. And what normally happens on the health plans side, and I'm not saying this is the way it should be, but this has been my experience, is that we do data sharing. So I'm getting to the ease of sharing. We do data sharing agreements with our vendors, with the providers, the physicians, the hospitals, and we essentially pull in information from them. And because of the demands, like on the provider group and the practice group, they do some analysis of the information, but we're looking for care gaps because we get more information coming in. So we're looking for those care gaps. Say you're just not getting your blood pressure medicine when you have a history of hypertension. We see that you're not refilling them. It's a delay in the number of prescriptions you had. We give that to them. It's a care gap. So the ability is there. The opportunity is there. It still needs to be developed, those relationships. There is a limitation because of the proprietary information that is out there and people trying to build. And we have to kind of create a means that people could advance with their abilities, their business, and the organization, yet still share the information so that it's not kept siloed because of the need of individual business gain. So it's a tricky dynamic, but that we're advancing. We've been forced to advance during this period of time. So that's my response to your question.
That's fair. That's fair. Josh, from your perspective, somewhat of wax level maybe, but a different perspective. So what's your take?
Yeah, I think I mean, first off, what everyone's saying here is spot on. I come from an orthogonal approach or perspective on things too, and hopefully interlockingly with what these gentlemen are talking about too. We have clinical systems, if I can reduce it to that are trying to track social problems, and as I've repeatedly keep saying here, and please let me know if it's too much. We have community level problems that need holistic redressing or addressing from outside of the healthcare system. I think it actually burdens the healthcare system a bit too much by saying doctors, nurse practitioners, and clinical systems. Now, in addition to trying to still figure out interoperability from standards we started putting in place, 10 years ago, now also start tracking all this other data and make it really, really useful and meaningful and fix all these problems. I think it's actually kind of it's too difficult of a problem to solve. And this is where it goes back to your public-private partnership thing and other pieces pretty meaningfully. So data is the critical underlying factor that we need to really meaningfully address to solve social determinants. We can't study what we don't know, and we have so much more to unlock, I think, in terms of data between sectors. What Dr. Lewis was referencing before and what Matt said before too, I think are care gaps, but there are community gaps that I think still exist too, outside of what it might be most directly relevant to clinical care right now. And so I think from our perspective here, and many others hopefully would agree, we have more data to collect and harmonize that still just doesn't exist. They don't exist in our open data sets that the federal government puts out there. If they're not something that a clinical entity is tracking, there's still a lot of gaps to try and fill there. And so I think that's part of it. And certainly there are existing systems that just aren't part of it yet. So how do we integrate what's already out there? How do we adapt what's already out there? But then also, I think we need to acknowledge that there is a gap in other types of data that need to be collected and addressed. That's one piece. Harmonization of that data is I think the next piece. Just because we have a bunch of data doesn't mean we're going to be able to do anything with it. And so tracking and collecting data and then putting it into meaningful, and I'll use the distinction of health improvement versus healthcare improvement, I think is really critical too. Healthcare improvement, absolutely necessary. And we have ONC and ARC and other parts of HHS that are trying to develop clinical standards for social determinants and other interoperable pieces there. But I think we also need to think about how all this other data is holistically improving the way communities, cities, towns, states, tribes, territories are all improving as well too. And we haven't really cracked that nut just yet, but I think we're working on it. There are some initiatives I can really speak of sort of generally that are looking into federal data sharing. How do we start leading the way by making sure that our data at HHS, one is we have the data use agreements to talk to HUD and transportation and USDA and other folks to even do our research, but two, in a more activated sense, how can we then open that up for real use in the world? And so you started this conversation with analytics and that piece, and I think that's where it all comes together. If we actually start collecting all this data, both at the clinical level and at the community level, and turn it into something actionable, and maybe that's something that HHS can be leading at some point in the future. We have an Office of the Chief Data Officer now, which is a relatively new team here, but it focuses, I think, on the bigger picture perspectives of what health can be and not our health data can be outside of just sort of the clinical standards. So part of what we do there is to hopefully lead to dramatic change that will unlock this bigger picture interoperability conversation. Ultimately, I'm a big believer in community health as a really important metric that we're not really focused on yet. So how do we actually improve not just individual or population metrics that are reducing costs, but also at that community zip census level, making big dramatic changes there too, because all of it has to work towards something. And that's where I think we can help set standards to do that, or targets, if you will.
Yeah, I think that having an understanding of what does it mean to be doing it? So your point about, and I appreciate this analogy, sort of collecting more data, that's part of it. Harmonizing the data, so that's basically more instruments into the building, fine. You've got more instruments in the building, now what are they playing? And it doesn't make any sense if I'm playing Rachmaninoff, you're playing Bach, someone else is playing Mozart at the same time. That's a cacophony. It's a lot of great music, but it sounds horrible together. We've got to be playing it together. And then how am I listening to it, right? Am I listening to it live in the room? Am I listening to it over a headset? Am I listening to, what is that experience like? And then what do I use that for, right? And I think that may be, it may be slightly different for different parts of this equation. But I think that what you're making me think about, though, which is a question that I want to ask all of you, and we're coming to our last 10 minutes, is the data, more data sounds to some will sound to some communities like, more questions. Here come a whole lot more questions being asked. And when I say that, and I say that with that resignation, because there are so many communities, particularly underserved communities, that have been involved in the study of the study of the study, where the questions have been asked over and over again with from different angles, not necessarily by entities like any of yours, but maybe by academic entities that have a particular question that they're trying to respond to an RFP in, and coming back again and now saying, oh, and by the way, we want more. So which is why I think some of this conversation about, if I'm going to be providing you with this data, with these responses, then should I not be getting something for it that I don't have to necessarily wait for way down the street, which is, well, we're going to be trying to improve your health outcomes. Yeah, that's going to happen at some point, but what about right now? So yeah, this is just a question that's sort of coming to my head as I'm listening to you all talk about this. Yes, more data is necessary. Yes, we need to harmonize it. We have to get more of it in first. What do you think are some of the ways that we might be able to get more and better data in to be able to do some of the things that we're talking about? Are you working at all in any of your settings on ways to get more in so that we can do more with?
Yeah, I mean, I'll start with a quick analogy to give others a little time to think about their answers, because I think someone else referenced this too, from maybe it was Dr. Lewis from his clinical perspective, but when I ran the community health center I mentioned before, it was actually an addiction center, and one of the biggest problems we had was therapist turnover. And I remember one patient, when one of our therapists left, they were really distraught about having to retell their story to a new therapist. It was to the point that they wanted to quit mental health altogether, and it was an addiction center, so they wanted to focus on just the addiction piece. And we really urged, apologized and said, you gotta stick with it as much as you can. And I'm sorry about this, but I think similarly, this past summer we did some research, some human-centered design research, where we actually talked to communities across the country, focused actually at the crosswalk of climate change and health equity and social determinants. And so we're talking to climate-affected areas. And one of the most common responses we got in that HCD process was, hey, we're here in Puerto Rico. We get hit by a hurricane every year, multiple times a year, and someone always comes and asks us a bunch of questions, and nothing ever changes. And same thing everywhere else that we've talked to too. And so I think, interestingly, your point is well taken, that we need to do better at thinking about how we're outreaching and getting data too, and not disrespecting communities, but also if we are going to come in and talk to people and try and do something, make it actually happen, have follow-up actually occur too. I think that's one thing that we're trying to engender here in this innovation team, is building a pipeline to communities that will hopefully be the pipeline for communities, between the feds and communities, and maybe in that process actually be able to build trust, because they can hear from us more directly. And so I don't know what that pipeline looks like. I don't know what technology, if that's technology, if that's just us picking up the phone more, but either way, being methodical in the way we think about it is a form of or a way that I think we can respond to your question, which is understanding and empathetically thinking about how these communities are dealing with things, or people are dealing with things too. But other thoughts?
Well, I can tell you a little bit. One of the things you said that really stuck out to me was talking about one of the things I love about working in social determinant space is that you know, when we look at healthcare, so many things in healthcare, and we've all experienced these are long-term in nature, right? You're treating someone's diabetes over the course of years of their life and or their cancer treatment or whatever. But in social determinants, so often we have the opportunity, the rare opportunity to address something in the moment that changes people's lives in the moment. And it's a very powerful thing. And when we can do that, it means something to the individual. But the worst case scenario is when we ask them the question and then we don't meet the need. That's what we have to try to avoid. And so, you know, I think that is foundational to everything that the groups that we work with are trying to make sure that when we're doing that screen, we're doing a full prepare screen with someone, that when it's done, we're actually getting them in contact and helping them meet the needs that are addressed, and not just sending a referral out through a system, but actually walking them through the process. And so I think that's a really important piece to this. But when it comes to, you know, the data components to this, we're actively working with a couple of states right now to walk them through a process by which we want to help them to really do a full gap analysis of need based upon resources, based upon resource capacity, because they're really three different things, right? And so we're proposing with them to do a widespread screening process with large populations to really learn where their needs are and how the needs break down by geographic region, urban versus rural, and then take that information and drive it into what resources are available in those communities, and deeper, what's the capacity, so we can really understand where our gaps are. And in this instance, the gap is we have, again, 1,000 people that have food insecurity in an area where we can only manage 500 of them on a monthly basis. And so we can't ever meet that need until we close the gap in how the CBOs are able to give out food. That's a big part of this. But the other piece to it is that technology is an amazing thing. We live in a great time in our country, and there's a lot of different ways to move information around. And one of the things that our team feels strongly is that when if we look at the top 10 needs around the United States, they're almost always consistent, right, across the board. We have the same top 10. The order changes a little bit, but the actual needs don't typically change a lot. But the question is, which of those needs can be addressed through some kind of a technological or educational resource tool versus which of those needs need to have a high touch, you know, wrap model where a CHW is walking them through the process. And that is probably going to be different based upon the geographic region that the individual lives in within an individual state. And so we're saying to these states, we want to build a best practice model that's specific to your area, your geographic realities, and it's going to be different in one part of your state than it's going to be in another part of the state. But once we fully understand that, we have the gaps, we have the data to show that these are the needs, we have the data to show where the needs are more prevalent and which ones need a wrap versus which one needs education, then we can go back to that all important point on this, which is policy change, right? To get the policies where they need to be in order to fill the gaps and allow these type of best practice models to actually have the biggest impact.
Very good. Okay, thank you. Dr. Lewis?
Hi, both of you have hit on some points that sparks an idea for me. First of all, I would say that there's a lot of information that we're not capturing, and that's why I mentioned the tools of the natural language processing. There's lots of clinical information to the record that is just not making it to the data platforms that would yield a lot of information that would help with social determinants. So that's there. On the other, in addition, in getting more information, I don't see this as an opportunity where you just sit and do a survey and pull information. I see it from a certain viewpoint, the viewpoint which one I try to practice. I'm not coming to you as the sole source of knowledge and information. You're going to feed me and I'm going to tell you what to do. I'm going to go from there. I see us on an even setting. You're giving me something, I'm going to help you. You don't know how you're helping me, but in that process, Matt mentioned power, and there's power and self-empowerment when people realize that you're working together for a benefit. It could be their benefit, and obviously they're thinking of themselves, they're thinking of someone like them. That's why so many people work with these advocacy groups. So there's an empowerment that you have in having that conversation when you're eye to eye in that conversation, not this, you know, superior, all knowledgeable one that's sitting up there. So that's the perspective that I see where it is helpful and easier to get the information. And then Josh hit on the big point, and that is trust. If I trust that you're coming to talk with me to assist me and you're genuinely going to work on it and you're interested, and you're not trying to fulfill some kind of personal need, it just flows naturally. So that's the perspective that I see in getting additional information, but I do see that there's plenty of information out there to help guide us in some of our decision making.
Yeah, no. Those are, and I appreciate that each of you are able to pull from, and you've not met before, at least not to my knowledge, you're able to pull from each other's comments, even though you're coming from slightly different spaces, but you're all heading in the same direction, maybe in slightly different vehicles, but heading in the same direction and wanting the same things for the communities that we serve. And those points that you just made, Dr. Lewis, with respect to partnering with somebody and like, as we like to say in human-centered design, designing solutions with rather than for people is a key element to the trust building piece that goes on. But it's also and this sort of speaks to this other element. We talk about COVID a lot with respect to what's impacted our last couple of years, but also this country has gone through this sort of racial related reckoning conversation that we've been having that has highlighted a number of different things related to diversity and inclusion and equity itself. And the notion of power and how power is shared or not is something that comes up in community conversations that might be captured in a dialogue way or in a text-based way that a natural language processing tool may be able to be put to use in, but that won't necessarily be captured in a medical record or in a health record, because that's not the context in which that conversation happens. And so where and how we're collecting data is going to impact that different data that we collect. And I think that needs to be informed to some extent by what Matt was referring to as the gaps in data, and identifying what those gaps are, and then creatively filling those gaps with this trusted partnership type of connectivity that we can have. We are at time. So many gems from this conversation, and I appreciate all of them. Loved again the Community Health Worker Little Black Book, how we go about doing this predictive analytics, and whether or not we're going to be able to get the right kind of data from people and understanding what that means. The harmonizing of that data is extremely important, and how we build trust through partnerships, be they public, private, or really just person to person. And the other thing that often gets lost in tech-related conversations is tech doesn't solve anything by itself. We need people to be engaged in that process, be they as users or designers or developers or whatever it is, or intermediaries like community health workers. And we need for that to be the case going forward. So I'm at time. Thank you again, Dr. Barry Lewis from Centene, Matthew Goodrow from Activate Care, and Joshua Prasad from HHS. Thank you very much for your time this afternoon and in leading up to this conference as well. The preparation for this has been outstanding, working with all of you.